Hello friends and welcome back to Perspectives Pulmonology. In today's video, we are going to study regarding Gina 2022, a very important topic and what is new in this Gina 2022 compared to the previous Gina. So initially we'll study in the nutshell what is the new things that they are added in Gina 2022 and then we'll study in detail regarding the management. So burning topic, asthma and COVID-19. What Gina 2022 says that there is no increased risk for COVID-19 in patient with well-controlled mild to moderate asthma. There is an increased risk if there is a severe asthma patient who is hospitalized and the patients who are taking oral corticosteroids. Okay, no risk for well-controlled mild to moderate asthma, but see increased risk for severe asthmatic patients who are hospitalized and patient on oral corticosteroids. And they have changed the diagnostic approach for the patient who are already on controller therapy, which was not there in the previous old Gina. And what they are told is better to avoid the term mild asthma because there is no clear-cut definition. But many people still use, we all still use in the clinical practice. There is no wrong in using it, but you are using it. When you are using it, you have to tell the patient that even though they have mild asthma, but there can be increased risk of exacerbation. Because what happens when you label the patient as mild asthma, they after cessation of the symptoms, they stop the medications and again they come back with exacerbation. So I have to teach them that mild asthma, even with mild asthma, they have to be careful regarding exacerbations. Regarding the treatment, what is the change they have made in the treatment? There is two important things that changes are being made. One is inclusion of as needed inhaled corticosteroids with formoterol among all the reliever steps across all the reliever steps, and addition of new biological treatment that is anti-TSLP, that is thymic stromal lymphopoietin. Example is temozolomab. Okay, two important things: addition of as needed inhaled corticosteroids with formoterol across all the reliever steps. Second, addition of new biological treatment that is anti-TSLP, that is thymic stromal lymphopoietin. Okay, coming to the flow chart of how we diagnose the patient with asthma. A patient coming with the typical asthmatic symptoms, that is cough, wheeze, tightness of chest, breathlessness. We do physical examination. We find that there are rhonchi, there are wheeze, and there are reduced breath sound. Then and we see that whether the patient is already taking control therapy. If no, then we see whether the patient has severe asthma. Some patient they directly come with acute exacerbation. That time we won't have time to do PFT and all those things. That then but in those patients we directly start treatment based on clinically diagnosed, and we review the response after 1 to 3 months. The patient comes with mild to moderate asthma. We do a PFT. We see for pre and post bronchodilators FEP1. If there is a change in pre and post bronchodilator more than 12% and 200 ml, we label them as asthma and treat as asthma. Sometimes what happens, the PFT will be normal, but the patient but clinically we'll be having a strong guts that patient has asthma. We label as clinically diagnosed asthma, and we start the treatment and review the response after 1 to 3 months. Some patients they have clinical symptoms of asthma, but it is somewhere it is not fitting into asthma. Even the PFT is not fitting into asthma. Then we need to look for alternate diagnosis by doing more tests like HRCT, bronchoscopy, whichever is fitting into those, and then we rule out the alternative diagnosis. Okay, this is the flow chart regarding diagnostic flow chart for asthma. Coming to the asthma assessment of asthma control, for this the patient should be on asthma treatment for minimum of 4 weeks, and then we need to review him. We need to ask him four main questions. One, that is daytime asthmatic symptoms more than twice a week, yes or no? Any night awakening due to asthma? Any limitation of activity due to asthma? Whether reliever needed for symptoms for more than twice a week, yes or no? If there is no yes, then it is well controlled. If he has 1 or 2 S, it is partly controlled. If it is 3 or more S, then it is uncontrolled. Okay, these are the 4 questions for assessment of asthma, where the patient should be on asthma treatment for minimum of 4 weeks before assessing the asthmatic control. Initial treatment, a very important slide. Be cautious here. You have to be very attentive here. It is, but this initial treatment means whenever you diagnose a patient of asthma, how do you start the treatment? That is what is being shown in this slide. But this is mainly for adults and adolescents, that is more than 12 years of age, not less than 12 years of age. Okay, we have two rows here, upper and lower. Either you can follow the upper regimen or lower regimen, but I prefer the upper regimen because here controller and reliever medications both are the same. That is ICS with formoterol. The patient need not buy a new drug. Okay, coming to the upper regimen, here if the patient has symptom less than 4 to 5 days a week, then we include them in step 1 and 2, and we start as needed low dose ICS formoterol. But if the patient has symptoms of most of the days and awakening due to asthma for more than once a week, then we include in step 3 and we start low dose ICS with formoterol. The patient has daily asthma, daily awakening more than once a week, and low lung function, we include in them step 4 and start them on medium dose ICS with formoterol. Here we can add oral corticosteroids also. All the patients who do not, the symptoms did not subside with this step 4, we go to step 5. What is there in step 5? We add long acting antimuscarinic agent. We send on for phenotypic assessment. We do serum Ig. If the serum Ig elevated, we give omalizumab. We give anti-interleukin 4, anti-interleukin 5, anti-interleukin 5 receptor antagonist. And one more important thing which we discussed in the previous slide, we give anti-TSLP, that is thymic stromal lymphopoietin. Okay, that is in the step 5. Remember it. Okay, this is step 5. Step 1 to 2, low dose as needed, low dose ICS. Step 3, low dose ICS. Step 4, medium dose. Step 5, high dose with LAMA and IgG and all those things. Okay, millimonoclonal antibodies. This is the upper regimen. Coming to the lower regimen, here the step 1 means the patient who have symptoms less than twice a month. That time we give ICS whenever SAPA is taken. In step 2, the symptoms more than twice a month, but these symptoms are less than 4 to 5 days a week. We give low dose maintenance ICS. In step 3, symptoms most of the days or awakening due to asthma, we give low dose maintenance ICS LABA. And step 4, daily symptoms, awakening with asthma and low lung function, we give medium bar high dose ICS with formoterol. If the symptom does not subside, again we go for step 5. The same step 5 is same for the upper regimen and lower regimen. Remember, we give anti-TSLP, a newer thing added in Gina 2022 in the step 5. Okay, this is initial treatment. Upper and lower difference is upper column regimen we use both inhaler, controller and reliever, the same drug, but in the lower it's different. Okay, this is, remember, it is mainly for adults and adolescents more than 2 years of age. Coming to how to step up the treatment. Short term and sustained step up. Short term is for 1 to 2 weeks. During viral infection or seasonal allergen exposure, we step up for 1 to 2 weeks, and again once the symptoms subside, we come down. Okay, we step down. But sustained step up for 2 to 3 months for the patient whose asthma is uncontrolled on low dose ICS LABA, despite good adherence and correct technique, they may benefit with sustained step up for 2 to 3 months. Okay. Stepping down the treatment, when do you step down? When the patient symptoms are controlled for 2 to 3 months and the lung functions have reached a plateau. Means when you do initial PFT and then you do consecutive PFT, the FEV1 has improved. That time you step down the treatment. How do you step down? First we reduce the steroids. If the patient is on oral steroids, we stop that. Then we reduce the inhaled corticosteroids by 20 to 50% at 3 months interval, because that is considered to be the safest. Otherwise the patient may go for exacerbation. Okay, this is regarding management, initial management, step up and step down of the treatment. If you have any doubts, please leave it in a comments box, and please like, share and subscribe Persetis Pulmonology. Thank you all for your patience listening.